Hello and welcome everyone. I'm just seeing people joining, so I'll give it a few seconds. Great, so people will start trickling in, but that is okay. So thank you all for joining us today. Our presentation today is on induction of labor and labor induction management. Following the presentation today, we will have a 10-minute question and answer period. Again, like all webinars in this series, this presentation is eligible for nursing continuing education, which is provided by SCL Health. So we'll be providing a QR code at the end of the presentation so that you can obtain your certification. During the presentation, feel free to chat in questions and I will answer them following the presentation, or you can ask at the end and I can unmute you. So our speaker today attended Harvard Medical School and then completed his residency in obstetrics and gynecology at NYU School of Medicine. He then practiced in New York City before moving to Colorado in 2021 and began working as an OBGYN at Denver Health. Dr. McClelland has multiple publications about cesarean delivery as well as induction of labor. He also serves as the board of directors at CPCQC, as well as the co-chair for the SOAR Collaborative. Please help me give a warm welcome to Dr. Spencer McClelland. And I know you can't hear everyone, but imagine them clapping.
I can feel the warmth. Hello, everybody. Good afternoon. I'm assuming most people are in the afternoon category at this point. So thanks to Katie and Elena for hosting. And I'm going to go ahead and share my screen, which is the PowerPoint that I'm going to take everyone through. And we'll make sure that that works well. Oh yeah, that's a picture of me. And I'm going to move very slowly during this so that you actually believe I'm outside at Red Rocks right now instead of in my office at Denver Health. So just want to make sure, is this coming through as the slideshow right now? Perfect. Okay, so we've given it the nice kind of poetic, chiastic title of Induction of Labor and Labor After Induction. In addition to being a general OBGYN at Denver Health, I am the physician lead for our women's care clinic. So I get to think about issues like this from a systems perspective as well, in collaboration with the other members of our division and nurse midwifery colleagues here. And, you know, we're going to go through a lot of topics here, but at the kind of end of this, what I hope for as priorities is that there's really a sense of just sort of on paper, if you were doing your elevator pitch to somebody for kind of best, most efficient induction methods, you could concisely walk through the evidence. But also to kind of take a step back and talk about the bigger systems issues, which include patient preferences and different birth experiences, and then the systems issues related to busy labor floors and staffing and how induction of labor is affecting the crisis we have these days, for lack of a better word. So to get started, I have no disclosures, hooray. But in terms of my bona fides, I always feel a little bit awkward, but I think it's worth kind of just saying what my background is and why you are listening to me talk about induction and why you might give any sort of credence to what I say here today. I'm finishing up my 6th year in practice. I now work at Denver Health, but for the first 5 years after graduating residency, I was in the same private practice in New York City. And during that time, those 6 years total, I've worked at 3 different hospitals, NYU first, then Lenox Hill Hospital as well in New York City, and now Denver Health. 3 hospitals, 2 different states, a mix of private and public hospitals. And I train in a mixed setting, both in the sense of a public and private hospital training, but meaning alongside a nurse midwifery service as I trained as well. So, and I now currently practice in a collaborative model with a nurse midwifery and family medicine complement on our labor floor as well. So I have, hopefully, even though being a doctor, a perspective on multiple opinions and perspectives on this process. And then in terms of the real bona fide part of this, I was in a very hands-on practice. So now I'm in a more academic supervisory setting. But during my time in New York, delivered about 800 babies, excuse me. And my personal rate that I kept track of for nulliparous term singleton vertex babies, that C-section rate was 11%, which I'm proud of. And that meant that I was involved in a lot of inductions and really feel that at the end of the day, what I'm about to talk about from an evidence-based perspective has been corroborated by my own personal experience. And I'll kind of color with that along the way. In terms of outline, we're going to spend a lot of time disproportionately focused on the early part of labor, early part of inductions, excuse me, because really that is the goal of an induction, is to get someone into active labor. And from that point forward, the quote unquote labor after induction part of this dovetails more with familiar labor management. So we're going to talk about cervical ripening agents, both pharmacologic and mechanical. We're going to talk about the role of artificial rupture of membranes, which I'm going to spend a lot of time emphasizing. We're going to talk about considerations for oxytocin. We're going to talk about multimodal induction, meaning multiple agents at the same time. And we're going to talk about really putting this all together, how when you're managing a labor, do you decide that the induction is working or not, and whether you're crossing over into active labor or your efforts have been unsuccessful. And along the way, we're going to have some digressions because I can't help but digress, and some big picture thoughts as we end. And here's a warning to start. This is sort of the Dante's Inferno warning of as you enter into any talk by somebody who's sort of giving an opinion on a topic, just be really skeptical about what you're hearing in good ways. There's at least one study to prove each side of an issue if there's not kind of consensus on an issue. And as my office mate, who may kind of morph in and out of the background at some point, likes to point out, the less evidence there is on a topic, the more strongly people hold their particular beliefs. So I'm going to try to be a really reliable narrator as we go along and point out where you're hearing more of my opinion or more of the evidence, so that you can make informed choices about what you're hearing. With that in mind, I'm going to use this schematic as we go, which is really that I'm going to try to highlight in the top right of each slide whether these summaries are giving kind of more just clean evidence-based facts, or whether it's more my personal opinion or kind of an opinion that is informed by the evidence. And that doesn't mean you have to just reject the opinion stuff, but kind of you can use it to navigate. So here goes. So I'm going to start with just a provocative statement as we get into talking about cervical ripening methods. And that's going to be to ask, how much does the Bishop score really matter? So the conventional wisdom around the Bishop score is that it helps us predict the success of induction as compared to spontaneous labor. Now, successive induction means that if you're going to induce someone compared to having that person magically go into labor on their own, how likely are they to have a vaginal delivery with that induction versus their own labor? By extension, it's been used to guide the need for cervical ripening. So the need to improve the dilation, effacement, and other characteristics of the cervix prior to initiating oxytocin. And so that's really kind of the second level of how the Bishop score is interpreted from its initial meaning. But that's how we use it in practice, is you're trying to improve the Bishop score before starting oxytocin. The citation that I have here by Gibson and colleagues is one of many, many, many studies that was in the lead up to the ARRIVE trial. This won't be the only time during today's talk that I invoke the ARRIVE trial, since it's having such an impact on our practice. But this was one of the bigger studies that was a retrospective study looking at the question that the ARRIVE trial looked at as well, which was the question of elective induction versus expectant management. Expectant management meaning letting someone remain pregnant rather than inducing them. And much like the ARRIVE trial results, this trial showed that there was a lower risk of cesarean delivery at each week of gestational age as you went along. The interesting thing, and the reason that I'm invoking this right here, is this finding was true regardless of the Bishop score for patients. So high versus low Bishop scores, favorable versus unfavorable cervixes did not seem to affect the likelihood of having a vaginal delivery versus a C-section. And even though it's not one of the main findings reported in the ARRIVE trial, it's certainly in there as well, in their findings as well, that the Bishop score doesn't seem to matter. So I just want you to hold on to this idea as we go along, because we're going to talk about cervical ripening methods. I'm going to slightly deflate or redirect the importance of this as we go along. So in terms of the specific methods we have, the pharmacologic ones are almost primarily and universally the prostaglandin analogs. And there are a variety of acceptable agents, routes, and doses that we use. Probably a lot of this is determined by just the hospital that you practice in. And across the board, the category of these medications are effective at reducing the cesarean delivery rate and reducing the failure to deliver vaginally within 24 hours. But of course, the flip side as their main complication is the potential for causing tachysystole. Now, tachysystole breaks down into tachysystole that causes changes in the fetal heart rate and tachysystole that doesn't. And this is almost always in these studies, tachysystole that does not cause fetal heart rate changes, which makes it the less worrisome type. So long story short, these have been around for a long, long time as cervical ripening or induction agents. And the two main ones in use these days are Cytotec, which is misoprostol, and Cervidil, which is dinoprostone. Cytotec can be given by a vaginal or oral route. Those are the main uses. It can also be given by sublingual or buccal administration, but those are much less well studied. Then the obvious advantages of Cytotec are that it's very inexpensive, it's shelf stable and doesn't need to be refrigerated, it's easy to administer. The downside is the need for multiple doses to see an effect. And for Cervidil, it has more of a set it and forget it. So if you're at a hospital or have ever been at one where they use Cervidil, it's an insert on the end of a string that goes into the vagina and can stay there for up to 12 hours. I think it's particularly popular in private practice settings where it's just something that can be done remotely on behalf of the private practitioner without needing to be on site. But the downside is it has higher rates of tachysystole and it is expensive. It is many fold more expensive than the Cytotec. So probably this is determined by your hospital, which one you use, and you're familiar with how to use it and what your protocols are. Now for the Foley, I'm going to spend a bit of time on this because it's really taken off as a popular modality of cervical ripening. But there are a lot of considerations in how to use it. And there's by no means the kind of like cleanliness of just saying, this is how you use this agent. I think the three considerations that I'm going to go over are the question of single versus double balloon Foleys, the question of placing it on any degree of tension versus not, and the question of whether or not to use it with rupture of membranes. The single versus double balloon question, I will just come out and say at the start of this, I'm a single balloon fan. But if you look at the data, there's no real difference in the cesarean delivery rate or other outcomes if you look at sort of the composite data from most of the studies. The single is certainly more cost effective because it's essentially the same thing as your run-of-the-mill Foleys, whereas the double is the proprietary Cook balloon. But I will say that I have a preference for single that I've really held on to ever since some of the earlier studies, and the second citation at the bottom here is the one that I referenced for this. This was a study that, unlike many of the others, did show a difference in delivery outcomes, and what it showed was a reduction in the spontaneous vaginal delivery rate when using the double balloon. That means that their composite of operative vaginal delivery and C-section was higher in the double balloon group. And for those of us who glommed onto this finding, the plausible explanation was that because the single balloon and the double balloon just have a difference in terms of the amount of space they occupy and therefore how much station you may lose or displace in terms of the fetal head, you may be really just sort of setting yourself backwards in terms of your starting point for an induction and trying to make up that distance over time that the head needs to then descend again. I think there's also a logic that the single balloon is safer by the same token that with the double balloon, because it's displacing more for the sort of freak occurrences that we worry about with cervical balloons, like cord prolapse or a baby that flips to transverse or breech presentation mid-labor, that those would be more likely as well, even though that's harder to prove in studies because it's such a rare outcome. So again, you could look at this different ways, and on the Rorschach test of like, what do you believe out of these studies? People will go different ways. I'm a single balloon person for the reasons that I stated. Now, when it comes to tension or not, this is another topic where, again, you'll get people who fall on different sides of this. The consistent evidence in the studies that look at this is that the more when you place it on tension as opposed to not, there is a shorter time to expulsion, meaning a shorter time to the balloon coming out, but that there's not a shorter time to delivery. And I'm just going to say, I'm not going to accept that finding, and I want you to hold that thought for a few more slides until we get to the topic of amniotomy. Now, these studies have some pretty medieval ways that they described placing tension. For some of them, it was tying a saline bag on the end of the balloon catheter and hanging it over the side of the bed. I don't know a word other than medieval to describe that. Commonly these days, when we're talking about tension, it's to place it on some degree of traction and tape it to the patient's thigh, which then of course means that you need to be attending to it frequently to make sure that that tape is staying. The last comment on the tension versus no tension issue is that I think it's probably safer to have tension applied when using the single balloon. And that's because the single balloon doesn't have the safety check of the secondary balloon that keeps it well applied to the cervix. So I have seen sort of more freak occurrences of balloons that were placed way too high using the single balloon, in a case of things like facial nerve palsy in a baby and placental abruption. And these are the things that are obviously user dependent, but which you have some degree of safety if you're placing it on tension so that it doesn't go wandering. The last comment is with regard to rupture of membrane. So this is, like the two other topics, a pick your own side of the issue thing. I think there's a belief that when you have fewer interventions when patients break their water, that this might be a nice one to improve the efficacy of your induction. But the data is really not persuasive that it improves the time to delivery over just using pharmacologic methods instead. And it is also unclear in this data, and again, take this positively or negatively, it's unclear whether there is an infection risk. So the theoretical risk is by having a foreign body when a patient's broken their water, you're increasing the chance of an ascending infection. But the data hasn't borne that out. So the believers in using the balloon with rupture of membranes will say, well, if the data didn't show it, then that risk probably isn't there. And the other people will say, well, if the data didn't show that it's safe, then I'm not going to use it. So I'm going to leave that as our comments for the Foley. Now, AROM. So this is probably, I think, the single most important slide in my whole talk, which may sound silly because there's so much other kind of pharmacologic subtlety potentially otherwise. I think this is the most important slide because I think that the topic of rupture of membranes in induction management and labor management has become controversial in this day and age in a way that it shouldn't be. I think it's controversial for a few reasons. I think one, there are questions just around efficacy and safety and whether it makes sense to do it. And then the second category is this sort of patient-centered conversation of whether breaking water represents something that is aligned with patients' wishes or is humane or fair to patients. I will use those words. And I'm using those words because those are the words that often get invoked when people are against breaking patients' waters. We are here to talk about induction. And we're talking about all the induction techniques. So from the perspective of just that first category, the efficacy and safety conversation, the data is just absolutely clear. And it has been very, very clear and consistent from the earlier studies up through the studies that repeat this question. So multiple trials show the same thing regarding amniotomy at what's considered earlier rather than later. So I'm going to pause here for a second, though, and say, why are we even breaking it down in this regard? We're breaking it down in this regard because I think there's this kind of wrong-headed thought on some people's part that the amniotic sac is just a passive barrier that at some point you got to get out of the way before a baby comes out. Unless, of course, you're delivering on call like the Dalai Lama, in which case that's a cool thing. But for most people, they agree at some point you're just going to get it out of the way by breaking the person's water. That implies that it actually has nothing to do actively with the induction process, whereas breaking someone's water, amniotomy, is a really active part of what potentiates oxytocin and causes an induction to really kick into high gear. So rather than talking about whether it's just okay to break someone's water at some point when they are like 8 centimeters, the question here is really to do it earlier than you might just treat it if you were treating it passively. So the trials that look at this have almost always defined early amniotomy as 4 centimeters or earlier. Keep in mind that very often these days now we are looking at patients who are 4 to 5 centimeters by the time their Foley balloon comes out, because that's the diameter of the balloon. So it's really the question of like doing it as early as you can. And these trials have shown consistently that there's a shortened time to delivery, an increased proportion of patients delivered within 24 hours of the time of the start of their induction, and no increase in infectious complications or any other complications. And of course, the infectious complications, that's the main concern from a safety standpoint that people invoke, is that if you break someone's water early, they're just gonna sit there, not in active labor, and develop an infection. And the key counter argument to this is, no, by breaking their water, you are pushing them forward and shortening the time to delivery, which, as we know, shortens the risk of an infection. And that's why these studies have never shown any increased risk of infection. It's important to emphasize that all of these findings are true in nulliparous patients. So this is not something selectively for patients who are on their 2nd or 3rd or 4th labor. This is for the first timer as part of your induction techniques. Now, as a kind of follow-up question to this, what about after a cervical Foley? So there are some who believe that once cervical Foley comes out, that's a really like artificial dilation that you've achieved. I do agree with that. That 4 to 5 centimeters that someone's at when their Foley balloon comes out is by no means the same as somebody coming in labor who's contracted all the way to 4 to 5 centimeters. So then there are people who say, well, because this is different than that laboring 4 to 5 centimeters, should we reserve a concern about breaking water right after the balloon comes out? And a new presentation from the most recent Society for Maternal Fetal Medicine annual meeting answered this question. And lo and behold, the exact same findings are true in patients who have their balloon out and then have their water broken on the early side rather than waiting. The same findings as everything listed above: shortened time to delivery, increased proportion delivered within 24 hours, no change in complications. So that's why I said when we were talking about Foley's and the question of tension to kind of like essentially reject the time to delivery finding, because this shows that if you are putting your balloon on tension, getting your balloon out sooner and breaking water soon after that, that you are therefore on track for a shorter delivery. So I wouldn't interpret the tension findings as saying that there's no reason to place balloons on tension. Another common thing as we get to category 2 of is why I think the AROM conversation is controversial, is this question of patient satisfaction, that it's inhumane, not patient-centered, interventional, aggressive, whatever word you want, to be breaking someone's water. And luckily, there are studies that have looked at this question with regard to patient satisfaction, and there's no difference in patient satisfaction with what is defined as an early AROM. So I think we also need to be very careful and push back on that part of the conversation, that this is just universally a not patient-centered thing to do. So I'm really noticing in the upper right corner of this slide, there's an E, and this last line I'm going to emphasize hard. The evidence on this is very clear. So I would prefer that we not treat this as a matter of opinion right now, okay? Moving on to oxytocin. So when it comes to oxytocin in the context of induction, I think there's a little fewer interesting things to say about it than there is in the context of labor management. So for labor management, when it comes to the package of interventions known as active management of labor, the advantages of high-dose Pitocin over low-dose regimens are clear. And in the induction context, a little less so. So if you're looking at specific outcomes on this question, there's really no evidence of increased success of vaginal birth against cesarean section or vaginal birth within 24 hours. There is some conflicting data on whether time to delivery is shorter with the high-dose regimen. And there's no difference in other outcomes, particularly complications. Now, if you are an individual practitioner within a hospital system, this is probably decided for you. You may have, your hospital have one regimen for all circumstances, be that labor augmentation or induction. And you may have different regimens for different circumstances. I am a proponent of high dose Pitocin for active management of labor. Maybe that should have gone in my disclosures slide at the beginning. And I am therefore also a proponent in the context of induction, as I fall on this side of the issue. But otherwise, I don't think that there's much that's falling into our control about oxytocin individually, because it's going to be determined by your hospital's protocols. The question of multimodal induction techniques has become more interesting recently, with these questions of looking at the conventional approach of dealing with induction techniques sequentially and going from one to the other versus overlapping them. And the real two specific questions are, in the universe of the Foley balloon being part of your techniques, should you be overwriting your prostaglandin, and should you be overlapping your oxytocin with the Foley? So for the misoprostol plus the Foley question, it is superior to using misoprostol alone. It not only results in a shorter time to delivery, but it results in a lower incidence of tachysystole and meconium staining compared to regimens that rely on multiple doses of misoprostol alone. And there's no difference in the cesarean delivery rate, no difference in the rates of clinical chorioamnionitis. As for the Foley and oxytocin question, this was actually a little bit of a ping-ponging opinion over the past few years, because one of the earlier studies said that to use them together as opposed to sequentially didn't make a difference. Then another study said it might, and now looking at recent meta-analysis on this, it shows an increase in delivery with 24 hours. So I'm just now going to put this all together into the kind of elevator pitch part of this, which is, if you are going to use prostaglandins, Cytotec's probably going to be the choice of preference. And you should just use it until you can't. Now, I leave that kind of vaguely because different hospitals are going to have different criteria about repeated doses, probably based on the number of contractions that someone's having or responses in the fetal heart rate that are going to determine when you're done using your Cytotec. More importantly, though, as soon as you can get a Foley in, get a Foley in. This may be the moment someone arrives. This may be only after some doses of Cytotec if they started with a closed cervix. But once you get it in, place it on tension, not just for efficiency, but also for safety, as I said. And then when you're moving on to oxytocin, presumably it's going to be while your balloon's still in, because you're going to stop your Cytotec at some point. So overlap your oxytocin with get your Foley out, break water, and continue on. It seems amazingly kind of reductive to put all these slides down in this, but that's actually how the data boils down. So moving on to sort of then the questions about managing the induction and deciding whether you're doing a good job and whether it's working, really becomes the question of, when do you call the need for a C-section? When do you diagnose that need? And what I've included here, this language, is directly from the kind of Bible, the master document that we're really all operating from now with regard to labor management, which is the first ACOG obstetric care consensus titled The Safe Prevention of the Primary Cesarean Delivery. And the language is that if the maternal and fetal status allow, cesarean deliveries for failed induction of labor in the latent phase can be avoided by allowing longer durations of the latent phase and requiring that oxytocin be administered for at least 12 to 18 hours after membrane rupture before deeming the induction a failure. So I'm going to go into a few points on this. First of all, this is not actually like a strict definition. This is a minimum criteria that they recommend that you meet, but doesn't tell you then in this last clause, quote unquote, before deeming the induction a failure, really how to deem it a failure. I'm going to break it down this way. Because of the clarity that our universe is getting now about active phase arrest problem, arrest of dilation, second stage arrest, arrest of descent, and then failed induction. Failed induction of labor to me is a latent phase problem. That means it is a problem that exists before 6 centimeters if we are agreeing to this new definition that the active phase of labor is 6 centimeters or beyond. Once someone reaches 6 centimeters or beyond, they are beholden to active phase standards, and prior to that, they are not. So please keep these two groups distinct. In projects that I've done looking at how we use these guidelines to diagnose C-sections, I have seen crossover in both directions. I have seen people who will call an arrest of dilation at 8 centimeters a failed induction if that patient happened to have started as an induction. And I have seen people call a failed induction arrest of dilation at 4 centimeters if 4 centimeters happens to be where someone got stuck. Keep these distinct, such that failed induction belongs to the people who are being induced and have not yet achieved 6 centimeters. And the other definitions exist beyond that. For that reason, I think that it's reasonable to use failure to achieve 6 centimeters as one of the criteria for deeming your induction a failure. So being on oxytocin, being ruptured for 12 to 18 hours at least while on oxytocin, and failing to achieve active labor or failing to achieve 6 centimeters. And that's what we're going to start using at CPCQC as our definition. And that's what I use in my own clinical practice. Now, the question then becomes, if you have this sort of range of possible times to be waiting, 12 to 18 hours, or potentially even longer, because they just said at least 12 to 18 hours, how do you decide 12 versus 18 versus 24 versus something else? And this is where I think I could probably spend an hour talking about all the complexities of the cervical exam and how we've been reductive recently about how we talk it and teach it. But remember that there's much more to a cervical exam than just the dilation number. We often say, well, she's been 5 for 18 hours, ruptured on Pitocin. But I'm always curious what the effacement is at that time, what the station is, what the position is of the baby's head. Because I would argue that somebody who's been stone cold the same exam, 5 centimeters, 50% effaced, -3 station, doing nothing that changes over the course of 12 hours is a person to be much more concerned about than somebody who over that time has had progressive effacement, progressive descent of the station, maybe some amount of rotation of the head to a more favorable position. And I would argue that there's never going to be an ability to codify this cleanly, but that you should be using those parameters to tell yourself, are you living on the earlier or the later end of this window that we're using to diagnose failed induction? For active phase considerations, I'm going to tell you I'm not in love with this slide, and that's because even though the name of the talk is about labor management after induction, that there's not as much unique, I think, as I said at the beginning, about the active phase if you've been induced versus the active phase once you've entered in spontaneous labor. But I do think there are some subtleties to keep in mind, particularly in the don't hinder your own attempts to induce someone by how you're thinking about the active phase. One of these points here is about the concept of transition. So yes, on the last slide, I just kind of leaned into this 6 centimeter definition, but let's remember that not only is that a new definition, most people here are probably familiar that it's from the Zhang and colleagues papers that have now redefined and informed the obstetric care consensus guidelines. And that those of you who've been practicing for a while will remember the Friedman curve, and that 4 centimeters was the cutoff for active labor. But that all the authors involved in that were consistent from the start, that these are population cutoffs that are not to be meant to be taken as a universal rule for every patient. So remember that your patients haven't read the textbook. Don't get hung up on the numbers, particularly don't get hung up on the dilation, as I said in the last slide. Use all the components of contraction pattern, dilation, effacement, station, everything to tell you whether this person's really accelerating into a different phase of labor. I will say this, and people might disagree with this statement, but it is uncommon for patients to sustain their own labor without intervention once they enter the active phase. It is certainly, we've all seen it, it's certainly more likely if someone had a really favorable cervix to start, or if they're multiparous as opposed to being on their first induction or labor. But I've seen many, many, many more patients stall because someone wanted to see what would happen or give a patient the benefit of the doubt and kind of pump the brakes on their oxytocin. as opposed to I have seen people mistreated by continuing on with their oxytocin. And then tachysystole is another topic I could probably spend an hour on. I think that this has been a great harm to patients from a systems perspective, is the obsession over tachysystole. So everybody here probably knows that tachysystole is defined as greater than 5 contractions in 10 minutes, averaged over a 30-minute window. And yes, tachysystole does have some negative outcomes associated with it, particularly tachysystole with fetal heart rate changes. But 2 things that I've seen happen are this. One is that there's really not anymore a distinction between the 2 categories of tachysystole, being with and without fetal heart rate changes. More importantly is I've seen just a kind of creep on the definition of tachysystole. So at the previous hospitals I worked at before coming here, it was very common for a patient to have the tachysystole label applied to them when they had 5 contractions in 10 minutes. Remember, the definition is greater than 5 in 10 minutes. But yet it felt that like pre-tachysystole was as pertinent a clinical entity as tachysystole itself. So I would say if you are at a hospital where this is part of your Pitocin protocol, part of your definitions, part of the guidelines for how you manage inductions in labor, then let's be really, really, really diligent about adhering to that definition, because that definition is the thing that's been associated with outcomes. Pre-tachysystole is not a thing. I'm going to move now into sort of like I've described, what I call the elevator pitch version of an induction, which is what I think is the best practice, and essentially how I managed all of my inductions in private practice prior to coming here. We have to recognize that this is not necessarily an approach that all practitioners are going to take, and not necessarily an approach that all patients are really like psyched about. And that's as true of patients who, are really, really, really pro medical care and interventions of pregnancy, as it is of patients who were hoping for a natural childbirth. Not everybody really wants to be induced. But let's keep in mind that there are different flavors of inductions, and that can inform to some degree how we go about our inductions. So there are certainly medical inductions, and then there are elective inductions. There are those that are informed by patient preference, whether they're more aligned with natural childbirth or not. And then there's the question of how time-sensitive inductions are. And I immediately just undercut the question of time-sensitive versus not by saying, is there really any induction that's not time-sensitive? And the reason I ask that is it's been well known that prolonged labor and prolonged induction are associated with increased risks to the patient, increased risk to the fetus and the neonate, and decreased patient satisfaction. And that's true across, please note, multiple different fields of the literature here, both the medical and midwifery literature. So with all this in mind, I would argue that all of the inductions should be handled in a time-sensitive and efficient manner. But the question then still becomes, which of these interventions are really acceptable to our patients? This is what I call the great dance, which is sort of how do you take what you consider a best practice and have the patient get on board with it. I think, we work in a really unique field in the sense that this is one of those areas of medicine that is has many, many more layers of thing going on than coronary artery disease might, or than osteoporosis might, in the sense that this intersects a lot with questions of identity, bodily autonomy, interactions with the medical care, the medical system, systemic racism. There's just a lot that goes into questions of reproductive health these days. So I'll say this from my own personal practice, is that expectations are everything. And I think there is a feeling that you're going to get a patient there to the hospital, and then that's when everything's going to get explained, and they'll all take everything you're going to say because you're the professional. That's not a good approach. Do your counseling ahead of time, because that's what prenatal care is for. And it can be tough in a group practice to have really a sense of responsibility of who's doing that counseling or how to execute it well, who's building the relationship with a patient to have that foundation, to have that conversation. I've had many sticky conversations with patients about the topic induction in my years of practice so far. And I'm really grateful that I had those in my office with time to revisit the conversation, sometimes over weeks, so that at least had a plan that we were decided upon by the time someone showed up. I saw many patients as a resident that I had to talk to myself, who showed up at the hospital with nothing covered by their doctors prior to showing up at the hospital. And I don't think that's fair to the patients, and I don't think it's fair to the staff on the labor and delivery floor to be wading into that on their own. I will say that in terms of expectations, we have to be very clear, particularly for patients who were hoping for natural or physiologic childbirth, that there is no such thing as physiologic induction. It is not a physiologic process by nature. So we have to just be clear and open and kind about how we state that. And by stating that, it doesn't mean that everything then has to go out the window in terms of someone's birth preferences. Point two about this is don't make assumptions about a patient's wishes. I see this in every direction. I see doctors make assumptions that because someone has signed up for MD care, that they are more accepting of interventions in their labor. And I have seen patients who are in the midwifery population who are assumed that they are okay to have a kind of slower induction. You're never right by making assumptions. And to that end, don't be monolithic in your approach. What goes wrong about making assumptions about patients' wishes is to say, well, this is how I do things for my patient population, or this is how they do things for their patient population. Therefore, this is the package of things that this person has to be willing to accept. Remember that birth preferences exist along a spectrum. Birth interventions exist to some degree along a spectrum. And even though I have a way that I say is what I think the best way to induce people, there are ways to negotiate and live in the middle comfortably. And oftentimes we make assumptions that because someone's have a preference for natural childbirth, that they might not be okay for any of the interventions, but there might be one in particular that is the sticking point. It might be having their water broken. It might be oxytocin. And until you sit down and talk, you won't know. We all strive to be patient-centered, but let's not use that term as a weapon within our community to imply that any approach is more humane than another. At the end of the day, we all can make faults in how we make assumptions or treat patients. So care for the patient in front of you, not the type of patient or the patient before this one that patient reminds you of, not the medical scenario, which you might argue dictates what's happening, not the time of day or the day of the week or the number of staff on the labor floor or any of those considerations. Having said that, I'm going to talk for about the view from 30,000 feet as my closing point, and then we'll pause for questions. Whether we like to admit it or not, each patient with a long induction impacts another patient, whether you see it directly or not. And for those of you who work at busy labor floors, you can probably easily summon a case of a patient sitting in triage with her water broken or elevated blood pressures or a scheduled induction who just can't get into a room on time because the floor is busy. And I'm sure you can summon at that exact moment someone who's been in a labor room with like a multi-day long induction. That's a very direct case, but even if you're not thinking directly about it, the busier our floor is, the less patients that we can accommodate. And this can turn into things like your hospital having to go on diversion and not being able to accept patients. You then don't see those people who are clamoring to be taken care of because, quote unquote, a blind eye has been turned. So I do think that we have to think about these inductions as not just about an individual patient, but about the domino effect for all of our patients. And the ARRIVE trial, this is not a talk about the ARRIVE trial, but the ARRIVE trial did instantly raise these very interesting questions about systems utilization. The worry was that the minute you had everybody being induced electively at 39 weeks, it would be so many people ahead of what their normal timeline that it would overwhelm hospital resources. The citation that I have at the bottom is another recent oral presentation from the Society for Maternal Fetal Medicine annual meeting that said that maybe the opposite is true, actually, that following a more routine policy of elective induction reduces systems utilization. And that's what they saw week by week as they looked at the elective inductions. I will say this, I think we are approaching a moment of reckoning where earlier induction may progressively be seen as the standard of care, not just for patient preference, but because of medical benefits. Now, the reason the ARRIVE trial and all these other trials have been plausible in the main finding that they reduce the C-section rate is that with later gestational ages, there's a higher risk of medical comorbidities, placental insufficiency, and fetal macrosomia as big hitters that might affect the ability of someone to deliver vaginally or to avoid other complications. So many people have started to use the term risk-reducing inductions as opposed to elective inductions, just to emphasize that this is not really only about choice, that there is a medical logic undergirding the topic of 39-week inductions. I will say that whenever that time comes that we have a moment of reckoning where 39 weeks is now the new 40 weeks, or where we kind of redefine what post dates or late term mean, these inductions may not be so elective, and therefore we may have to refine our system to accommodate patients who are now asking for what's considered standard of care. And with this in mind, regardless of that finding from the recent SMFM meeting, we are going to have to figure out how to take a predominantly induction-based world and make that work smoothly. And with that in mind, efficient, safe, and patient-centered inductions will be a key part of our path forward. And that's why I care that people know how to do efficient inductions. I'm going to end on that note and skew into the less professional and just go over my summary here and just say, look, we're going to set expectations first and foremost for patients in terms of what can be avoided and adjusted, what cannot, so that by the time we're starting an induction, we have a plan. As plans go, I think that this emphasis on the Bishop score is a little outdated. It may affect how long it takes to get into active labor, but might not matter as much for outcome overall. And what's more important is getting to the point of AROM, where our Foley is now a really key friend to this. The earlier you can get the Foley in, the earlier you can get the Foley out, and the earlier you can therefore rupture someone's membranes. That's the key step in addition to oxytocin. In terms of efficiency, multimodal induction techniques are more effective, no two ways around it. When the time comes though, be efficient about your management, but don't rush diagnosing failed induction of labor, as I stated. And as always, as people who are maybe the foot soldiers in the actual process of a big system, but yet nonetheless participate in the system and have a voice in your system, keep the 30,000 foot perspective in mind as your hospital is continuing to engage with inductions. And now here's my real skew towards the unprofessional, which is David Pumpkins. Time now to pause for any questions.
Thank you so much, Dr. McClellan. What a great presentation. I see that we have some questions popping up. So I will ask you the first one that came in from Dr. Fabry. And she said, great talk. You cite multiple trials showing decreased time to delivery, F beyond tension, early AROM. What is the time difference? Is it clinically important, i.e. 1 hour shorter?
I'm going to thank Dr. Fabry for all of the setups here. So the multiple trials for decreased time to delivery with the Foley balloon on tension or early AROM, the absolute difference is on the order of a few hours. Again, in this sort of like Rorschach test approach to this, anybody who's not really interested in that finding is going to say, what do a few hours matter? I will argue that for an individual patient and for the system itself, a few hours matters. And particularly for the system, if you're counting that kind of improvement over all of your inductions, that's a lot of resources gained back. Several institutional reports now on elective inductions that have seen increased rates in the NTSV cesarean rates. Think this can be related to RCT outcomes versus implementation into practice, effects of COVID, staffing shortages, et cetera. So yes, this is a question at Denver Health for us as well. And, there was always the skepticism when looking at the ARRIVE trial results that, in the real world, the external validity of this, is this going to match up at all? If you're going to take this what if by the very next day they just made it a universal policy, the worry was you were going to see the rates go up. And I think that is in truth gets down to that this is not a simple matter, and that's the kind of substance of this talk. It's not a simple matter of do an induction at the right time and everything else will follow. It matters how you do the induction. So I think the ARRIVE trial, as most trials looking at inductions are going to, have a pretty protocolized way that people were required to go through. The ARRIVE trial allowed for a certain amount of flexibility, but these were not willy-nilly inductions. And the real world is filled with willy-nilly inductions. So I think to have a hospital that takes on a policy of universal 39-week inductions without at the same time addressing induction techniques is going to see that problem most likely. There's a great study that I didn't cite in this that is one of my favorite of all times, which was a paper from Ben Taub Hospital affiliated with Baylor, where they looked at just an induction protocol. And that induction protocol was pretty rational. It was things like break water as soon as possible, put in an IUPC if people aren't dilating within the first few exams, titrate based on your IUPC to adequate Montevideo units, and then a strict definition for what's a failed induction of labor. And they saw their failed induction of labor diagnoses drop to practically zero. That didn't mean their C-section rate went to zero. They had other reasons that people required C-sections, but they solved that piece of the puzzle. And so, you know, we're doing work here as well about how to make our inductions more standardized and more efficient. And I think that's the key second part of what Dr. Fabry is hinting at. And then studies comparing early AROM or Pitocin versus Foley followed by PIT. I don't think I saw a paper comparing just this PIT AROM question versus Foley PIT. I should say, and I kind of left this out of this because there's only so much of my, you know, anecdotal experience that I think matters. My induction technique and my partners at my former practice, which I really think was bar none the practice that I would recommend anyone go to in New York City. We never used Cytotec. We only used Cytotec if patients, if we couldn't get a Foley in when they first arrived. So our standard technique was get the Foley in, start Pitocin at some point overlapping with that, get the Foley out and break water immediately. And then it was just a question of keeping your Pitocin titrated and, you know, actively managing your labor. So I don't know about sort of like AROM and PIT versus Foley and PIT as an individual question, because for me, there was just that standard approach. That's not to say why I don't know the answer to this, but, you know, I don't know that I need to know the answer to this. I want to go down to the question from Alexis Harmon, which is regarding AROM. It is great to also think about the burden on the patient decision. Even though this can affect 1 to 3 hours for time delivery, this may not be a significant factor for the patient, regardless of staffing and beds. So I want to make sure I'm understanding the question, but that the 1 to 3 hours difference might not matter to the patient, and therefore, when discussing this as a technique, not to sort of like emphasize it for that reason. I think that, you know, it's a great point. I think you always have to be careful about interpreting the results of studies and saying, because the average result in this study was 1 to 3 hours difference, I can therefore say to my patient that the difference for her will be 1 to 3 hours. You don't know that. I would say instead, the way to think about this is really the sort of like overall success question. That these studies not only show that there's a shorter time, but they show a higher rate of success of vaginal delivery within 24 hours. And that the big concern I have with delaying things like amniotomy, and we see this anecdotally enough in patients who have their amniotomy delayed, is the risk of developing an infection. Because an infection isn't just about, and this is the conversation that I have with patients in real time in my office or in labor, is it's not just about, did you develop an infection? Aw, shucks. It's not just about, did you develop an infection? Aw, shucks, your baby's now going to the NICU, which is not what you wanted. Sometimes developing choreo can be the Achilles heel that significantly enough impacts someone's contractions that they don't progress through labor. And that's to tease out from studies. That's a thing I've seen plenty of times in practice. So I do think that, you know, Alexis, to your point, I'm not just leaning into like, hey, 1 to 3 hours, doesn't that sound great? That you're like a parent 1 to 3 hours sooner. And I'm not leaning into it for the patient in terms of the systems perspective. I am talking about overall that there's much more that comes from an expedited induction in terms of benefits. I'm going to go to the next question. So AROM does not increase complications, but what about a patient who's trying to have an unmedicated birth? Now that person suddenly has variables where it wasn't happening before, continuous monitoring, IUPC, amnio infusion, leading to limited mobility, more likely having a CLE, whole cascade of interventions, studies that look at patient satisfaction. Are those patients self-selecting for elective induction of labor? Are they open to that cascade of interventions? Are they looking for some experience? This is a challenge for many midwives. So I think it's a great question. And there's a lot in that question. So, you know, I think that you've just sort of crystallized the question about AROM in the patient hoping for unmedicated / natural / physiologic childbirth. Let me tease one part of this out to begin with. So to your question about the studies that look at this, this actually wasn't even a study that was looking at, this was patients who were having inductions for whatever reason. And it was a question about timing of amniotomy. And that's it. So it was sort of lumping together a lot of varieties of reasons for induction. In terms of this cascade of interventions, this is a term that comes up a lot. It's a term that kind of like gives me goosebumps because it has a lot of meaning. I think the term first kind of became really popular with the business of being born in Ricky Lake. And this idea that once you have one thing happen, there's no getting around all the other things that happen. And I think, Anna, to your point, this is in our control. I do not believe that somebody has to have continuous monitoring, IUPC, amnio infusion, all of these things that follow. I think the idea for patients that automatically they're getting an epidural, then they're stuck in bed, then they're getting more Pitocin, then they need more epidural, then their labor stops. I think that's a really dangerous idea that's actually fairly disproven by all the studies looking at active management, amniotomy, oxytocin augmentation. Those have been really reassuring on that standpoint. So when I've had patients who have been on the unmedicated birth end of the spectrum, this is how I approach that conversation. I try to really carefully address the many points involved in this concern and really respectfully come at sort of what we're going for here. If at the end of the day, we are aligned on certain endpoints like the safety of the birth process and key principles of what that birth process looks like, then usually you can navigate through that. But I also don't use, don't you want your baby to be safe? Don't you want your baby to stay with you and not go to the NICU as, you know, bludgeons to get people to go along with a path, because that's by no means, you know, a patient-centered approach to this. So, Anna, I don't know if that satisfies the question, but I think you've pointed to the complexity of this, and that's just, I don't mean to be glib when I say this, that's the fun of our job, is figuring out how to marry a growing body of evidence about best practices and patient preferences that may at times not fit with that, and how to keep that patient in front of you in mind, but get towards the outcome that you think is best. I don't know if we have more questions or other time, but I think we're out of time.
I think we're out of time too, but I think that I don't want to speak for you, Dr. McClellan, but if people have questions, that if they could reach out to you, you'd be willing to do that. Is that correct?
Yes, I would. I absolutely would.
And Dr. McClellan's information can be found on our website at cpcqc.org, I believe.
And what are we?
And here's the QR code for nursing continuing education that was nicely provided by SCL Health. I popped up a post-evaluation survey. If you could do that, that would be really helpful for us. But again, I just want to thank Dr. McClellan for his time. What a phenomenal presentation. And we will have another presentation coming up in July on birth trauma. So look forward to those emails to come. And thank you all for attending today.
Thank you, everybody. Have a great day.